All right. So, good evening for Bangladeshi audience, and good morning for Dr. Mazen Kuralla. Assalamu alaikum. Today we're going to talk about very important topics on fluid therapy in sepsis. The title of the talk today is Fluid Stewardship in Septic Shock, De-escalation and De-resuscitation. We all know that fluid is the most common treatment modalities in shock patient, and in US only we use over 200 million liters of fluid to treat the shock patient. So it's a very common, but it's very complicated. Recently we found out too much fluid is not good. We also find out the difference between the balanced and fluid and the normal saline. And there's a lot of talk about, that balanced fluid is better than the normal saline in terms of kidney injury. So, and we all know too much fluid can cause ARDS, fluid overload, and can lead to a organ dysfunction. So today we all know about the de-escalation of antibiotic therapy, but so I think I like the title, the fluid resuscitation and the de-escalation and de-resuscitation. Today I'm very proud to introduce Dr. Mazen Kuralla. He is an associate professor, University of North Dakota. He's also the medical director, Critical Care Service, Stanford Health System. He's also the chairman of the ICU Reach. There's a great platform for the educational activity. So he's going to present a session. He's going to do the session today, and the title is again Fluid Stewardship in Septic Shock, De-escalation and De-resuscitation. We have three distinguished panelists from Bangladesh. One is Professor Nurul Huda. He is head of the nephrology Chirang Medical College. He's very involved in teaching. He's very academic, and I heard a lot of session on ABG and fluid resuscitation of his lecture. Today we have Dr. Fatima Ahmed. She is a professor in intensive ICU, one of the largest academic center in Bangladesh called Bardem. I know Fatima for a long time, and she's very involved in sepsis, and I heard a lot of presentations related to sepsis. Thank you so much, Fatima, to join. I have Dr. Motiul Islam. He is head of the department and also the consultant of ICU, one of the leading hospitals in Bangladesh, Asghar Ali Hospital in Dhaka, and he is very involved in teaching as well. And I have seen many sessions, not only as a speaker or panel, also he does wonderful moderation. So he's a great, actually, as a moderator as well. So. Without any delay, because I know Dr. Kuralla has to leave and he has a flight to catch up. So I hand it over to Dr. Mazen Kuralla to start his session. Thank you so much.
Indeed, it's my pleasure to be here again and talk to my colleagues in Bangladesh and around the world. And as Tasber alluded, fluid stewardship is essential in management of septic shock, especially after the resuscitation phase. At the end of the talk, we should be able to familiarize ourselves with this graph here. What you see here is the stages of fluid status in the ICU. And you can see that we go through stages from resuscitation to optimization to stabilization and then evacuation. This model is called the ROSE model. In each specific phase would have a specific fluid strategy. And we're going to talk about how we're going to implement this strategy in terms of given fluid based on our fluid responsiveness assessment method and based on our clinical evaluation and laboratory evaluation of the perfusion status of the patient. So I would start with a case of 32-year-old.
Mazen,
Yes.
1 second. I just forgot to mention one thing quick. There's at the end of the session, there is a question, the quiz, and Dr. Mazen Kurella will go through 10 questions. And there is we'll monitor that who is answering the right question, more and the right question. So whoever's the winner will get the wireless headphones. So and we'll mail that one to the winner. So Nafisa is monitoring that who is the highest and get the right question, and then we'll get the address from that winner and we'll mail it to them. Yeah.
Perfect. Thank you very much. So this is a 32-year-old female, past medical history of asthma, ulcerative colitis. She had colectomy and she's on chronic immunosuppressive agents. Presented with symptoms and signs of pneumonia. You can see on the chest X-ray. She also had septic shock, required vasopressors. She required intubation. She had multiple bronchoscopies for right lower lobe atelectasis and mucus plugging. As you see, her hemodynamics with blood pressure of 86, heart rate 119, and lactic acid of 3.4. She had some organ dysfunctions. PF ratio was 165, creatinine slightly elevated, and platelets 120,000. She was started on broad-spectrum antibiotics. Her procalcitonin was 3.87, and she was resuscitated in the ER before she came to the ICU with 30 ml per kg as per the surviving sepsis campaign guidelines. She continued to have intermittent boluses, and she was maintained after that on IV fluid. She was started on norepinephrine, and then vasopressin had to be added because of continued hypotension. And she was also on steroid therapy with the hydrocortisone 50 milligrams every 6 hours. Now, 4 days later, we could not culture any organisms. The MRSA screen was negative, vancomycin was stopped, and she was continued on ceftriaxone and azithromycin. Procalcitonin came down to 0.7, so there's a response to the antibiotic therapy. And it is now day number 4. You can see lactic acid improved down to 1.7, norepinephrine started to go down, and the vasopressin was still continued at this point, and she remained on steroid therapy. What's important to notice here that her fluid status has changed, and she was positive for a total of 9 liters since admission. At the same time, the intra-abdominal pressure was 15, the IVC was 2.3 centimeter, and with the ultrasound of the portal vein, we noticed that there's around 50% pulsatility. So all this would indicate that this patient had enough fluid, and probably it is time for the resuscitation for this patient. So patients with septic shock, sepsis is associated with generalized endothelial injury and capillary leak. Traditionally, we give large volume fluid resuscitation, and the surviving sepsis guidelines would recommend at least 30 or around 30 ml per kg to be given, or at least started within the first 1 hour. Of course, some patients will accumulate fluid. So what is the association between positive fluid balance, fluid overload, and outcomes in critically ill patients? And do interventions aimed at reducing fluid balance lead to improved outcomes? That's what we're going to be discussing here. As I mentioned already, the Surviving Sepsis campaign would recommend that we do the Hour 1 bundle. There was some debates about this bundle, but eventually was updated again. And the recommendation is to begin rapid administration of 30 ml per kg crystalloid fluid for hypotension, or if the lactic acid is equal or more than 4 millimole per liter. Of course, the other components of the bundle would include measuring lactic acid, obtaining blood cultures, administering antibiotics, and starting vasopressors for persistent, starting vasopressors early. Now, the question of this 30 ml per kg, number one, they did not define what do they mean by the weight. Is it the actual body weight? Is it the predicted body weight or the ideal body weight? And if we go with the actual body weight and imagine someone who has 200 kilos, he would end up having more than 6 liters of fluid as initial bolus. So that needed to be clarified, and it is not very clear in the guidelines. Now, it is important that we give fluid to those patients who are fluid responsive. And I want you to know that we are all fluid responsive. So if you have a healthy person and test whether he would respond to fluid or not, the answer is likely yes. The person would respond to fluids. And what do we mean? What do we mean by fluid responsiveness? Well, we need to look at the Frank-Starling curve. And we need to make sure that when we give fluid, and by giving fluid, we're increasing the preload for the patient. By increasing the preload, we need to make sure that there is an increase in the cardiac output, stroke volume, whatever method you have to assess for the stroke volume. And you can see if somebody is actually is residing on the flatter part of the curve, the change in the stroke volume would not be that significant. We would say the patient is not fluid responsive if the stroke volume variation is 10% or less. You can see the number between around 12%, 10%. But if it is higher than this, that means the patient residing on the steeper part of the Frank-Starling curve, and any increase in the preload is going to be associated with remarkable increase in the stroke volume. However, less than 50% of hemodynamically unstable patients are fluid responders. So if I give that 30 ml per kg to everyone who comes to the emergency room, I'm going to end up giving 50% of those patients fluid unnecessarily, or at least without having the expected or the anticipated fluid response. And in septic patients, where they have septic ventricle, where the ventricle is actually failing, so it's not early part of sepsis, it is at the advanced stages of sepsis, the Frank-Starling curve is actually shifted downward and to the right. You can see how flat it is. And when you assess for fluid responsiveness, if you increase the preload here, you're not going to get enough, you're not going to get appropriate increase in the stroke volume. Most likely, you're going to increase the fluid overload for that patient. And in this study also, for those patients who were fluid responsive, in this investigation here, they had 20 critically ill patients. They gave them 500 ml of IV fluid. And they tested the response in terms of cardiac index. And you can see here that after half an hour, 30 minutes, yes, they responded to the fluid. However, you can see within 60, 90 minutes, the cardiac index started to go back to the baseline level. So that increase in the hemodynamics is not persistent. And you can see that also in this slide here. You can see the initial percentage of patients who responded to fluid after presentation to the emergency room with septic shock was around 57%. However, 2 hours later, of course, some of those patients had fluid, but they are not responsive anymore. So if you continue giving fluid to those patients, you're going to end up having fluid overload rather than beneficial effect of the fluid. And you can see in 4 hours, we have close to 10% of those patients would remain fluid responsive. So that dictates that there is a need that you assess fluid responsiveness so you don't end up overloading your patients with fluid within the next few hours after presentation to the emergency room. And in this study also, they compared the fluid compartments of fluid responsiveness in septic and non-septic patients. And you can see that the dark bars are the septic patients, and those are the non-septic patients. You can see the intrathoracic blood volume after fluid loading is increased in non-septic patients. However, it did not go up in septic patients. And in this study, they found out that in critically ill patients with endothelial injury and leaky capillaries, less than 5% of fluid bolus remains intravascularly after 90 minutes. So it is clear that the practice of giving 30 ml per kg and continue to give fluid bolus will result in good percentage of patients in fluid overload, and that is severe tissue edema. This severe tissue edema will lead to impairment in the oxygen and metabolite diffusion, and it will distort the tissue architecture, and that will impede the capillary blood flow and lymphatic drainage. It will disturb the cell-cell interaction, and you will end up with what we call fluid accumulation syndrome. And the fluid accumulation syndrome is actually, it would manifest with symptoms and signs in multiple organs. But more remarkable would be in those organs that are encapsulated. There's not much space for this organ to enlarge, such as the kidneys, the liver, and the brain. In the kidneys, we're going to have interstitial edema, and that will lead to decreased blood flow and, of course, increased interstitial pressure. This will lead to decreased GFR and increased creatinine, and that's what we call renal compartment syndrome. And the renal compartment syndrome here is because of the fluid inside the kidney, but it could be also part of the abdominal compartment syndrome. In the liver, there's increased hepatic congestion, impaired synthetic functions, increased cholestasis, decreased cytochrome activity, and hepatic compartment syndrome. In the CNS, there will be cerebral edema that will lead to impaired cognition and delirium. The intracranial pressure is going to be increased, cerebral perfusion pressure is going to be increased, the intraocular pressure is going to be increased. So we have intraocular or ocular compartment syndrome and intracranial compartment syndrome. But we're going to see also evidence of this fluid on the GI system. You will see ascites, increased gut edema that will lead to decreased absorption and decreased contractility and ileus. The intra-abdominal pressure is going to be increased, and we're going to have abdominal compartment syndrome. At the same time, also, this fluid can have an effect on the heart by increasing the myocardial edema, and that will lead to conduction disturbances, impaired contractility, diastolic dysfunction, and that will lead to increased CVB and central pressures. Venous return is going to be decreased, and that will lead to stroke volume decrease and cardiac output decrease. So that means we're going to have hemodynamic instability because of fluid overload. Patients are going to continue to have hypotension, and that is because of the decreased filling pressures on the right side, because of the increased filling pressure on the right side and the decreased stroke volume. And we all know that this could be associated also with pulmonary edema, and we'll see pleural effusion and the gas exchanges will be affected. Those patients will going to stay on the ventilator for longer time, and they will have increased extravascular lung water. And the work of breathing for the patient to overcome this low compliance is going to be huge, and that's why they stay on the ventilator for long. And finally, the abdominal wall. I just wanted to go in details because, you know, we see all those manifestations in the ICU, but it's difficult to put them together. And I'm sure that anyone who's listening to this, it's like he's saying, yes, we see this, and now it is nice to put it all together. So in the abdominal wall, there's tissue edema that is increased. That will impair the lymphatic drainage. It will impair the wound healing, and that means also increased risk of wound infection, increased pressure, increased risk for pressure ulcers, and decreased abdominal compliance. And there are two terms that you need also to be familiar with. The first is global increased permeability syndrome, and this is when we have high capillary leak. And that is actually defined based on the capillary leak index, which is expressed in the as a ratio of CRP. CRP is inflammation over albumin albumin is oncotic pressure. So if that index is more than 60, it means we have too much inflammation, not much of the oncotic pressure to keep the fluid inside the vasculature. That will lead to excess interstitial fluid and persistent high extravascular lung water index, and you will not be able to achieve the conservative fluid management that we're going to be talking about. And of course, that's going to lead to organ failure. If you have 2 or more anatomical compartments with elevated compartmental pressures, this is what we call poly-compartment syndrome, and we talked about that. Now, if you go to in the literature and look at the outcome of those patients with different fluid management strategies, this study, I think in 2009, I believe, in 212 patients with acute lung injury complicating septic shock. And you can see here that if our initial fluid resuscitation was adequate and our post-resuscitation fluid management was conservative, this would be associated with better outcome compared to any other strategy. If you have adequate initial fluid resuscitation, but you continued giving fluid, look at the mortality, 55, 60% compared to around 20%. If you did not give enough fluid for resuscitation, and then you continued be conservative, your mortality rate is 40, 45%. And if you had inadequate fluid resuscitation at the beginning with liberal fluid management post-resuscitation, that has the highest mortality rate of around 80%. And this is actually replicated in different studies. Those are retrospective studies, observational studies, but you can see here also that the mortality rate, the gray bars are the mortality rate. This is the numbers here. You can see the mortality rate was the lowest when we have early conservative, late conservative fluid management strategy, followed by early adequate, late conservative. And we're going to be talking about this early conservative, early adequate. And what we mean by early adequate is the Surviving Sepsis campaign guidelines. Early conservative would be less than this, actually. And in this study specifically, early adequate was defined as more than 50 ml per kg of fluid in the first 12 to 24 hours. So it's not only the initial bolus. And the early conservative was less than 50 ml per kg. So that takes us to the concept of fluid stewardship. I think we need to manage fluid similar to the way we manage antibiotics. And I'm not going to present the complete stewardship program. This is evolving, and I think we have more literature to support the evidence-based different practices of fluid stewardship. But what I'm going to be talking about are the following concepts. First, fluid should have an indication, and we can have an indication being resuscitation, maintenance, replacement, or we're using fluid for nutrition. And then we're going to be talking about the ROSE model that goes through resuscitation, optimization, stabilization, and then evacuation. We're going to be looking at fluid as a drug. We have a dose for it, we have a duration, and we have a de-escalation for it. And then we're going to answer 4 questions: when to start fluid, when to stop fluid, when to start fluid removal, and when to stop fluid removal. So the 4 indications that we can give fluid for resuscitation, that could be with fluid challenge, meaning that we give 250 and assess hemodynamic response. Or we can give fluid bolus, we give 500 to 1 liter, and the goal would be to increase intravascular volume. And we can give the fluid for maintenance, just to maintain some IV fluid, and you need to notice that, with medications and without giving any fluid boluses, our patients in the ICU on average would have 1 liter of fluid. Or we can replace fluid losses. Somebody has diarrhea, diuresis, we can replace that actually with fluid losses. And finally, we use fluids for nutritional support when it is part of the TPN that we use for our patients, or it is actually to facilitate the administration of our medications, the IV medications, of course. And when we look at the fluid when we look at fluids as drugs, the drug would have inappropriate therapy versus appropriate therapy. We need to talk about type of fluid, and Dr. Islam gave us a very nice lecture about what is the best fluid for resuscitation in the intensive care unit, being the LR. And then we talk about timing of administration, when, how soon we need to give that fluid bolus, and how fast we give it. And like any other medication, if we consider fluid is a medication, that means we're going to be talking about its pharmacokinetics and pharmacodynamics. And of course, it would have some toxicity, and that's what I mentioned before with the fluid overload syndrome. And for that fluid would have duration of use, and it should be appropriate duration, and this should be guided by some kind of response, and it should be that response. And then during de-escalation, we can accommodate what we call late conservative fluid management and late goal-directed fluid removal. With the ROSE model, we go through 4 different stages. The first stage is resuscitation, and that would be the initial adequate fluid management. And per surviving sepsis guidelines, we give 30 ml per kg, but you don't have to do this now, actually, based on our recent studies. At least you should maintain some fluid resuscitation based on fluid responsiveness. If you're sure that your patient is going to be benefiting from fluid, give the fluid. If you don't see any benefit, and we'll talk about that. But with the resuscitation phase, we advocate to start vasopressors very early at the same time. Now, once we're able to resuscitate the patient, we go into optimization phase. And the goal of this phase is to establish perfusion and organ rescue. And the fluid should only be based on responsiveness to avoid fluid overload. And then we titrate vasopressors for hemodynamic targets. The aim here would be neutral balance. So in the first one, we're giving fluid aggressively based on responsiveness. And then the second phase, we give fluid, we aim for neutral balance with the fluid. We only give fluid if the patient continues to be responsive to fluid and try to avoid fluid overload. In the stabilization phase, the goal is to maintain perfusion and organ support. But in terms of fluid, since the patient is now stabilized, we need to start removing fluids. And the goal is to have 2 consecutive negative balance within the first week after the initial insult. So we monitor for fluid overload and organ dysfunction, and we try to aim for negative balance for at least 2 days in a row within the first week, and that's what we call late conservative fluid management. And in the last phase would be the de-resuscitation or evacuation phase, and the goal is to have organ recovery and removal of excess fluid. We can achieve negative fluid balance with different methods, including diuretics and renal replacement therapy, but we monitor for signs of fluid overload, and we establish those methods as early as possible once we identify that our patient is fluid overloaded. So now let's just look at how we put all this together. So the first phase is escalation, and this is the resuscitation phase. We're just giving early adequate fluid management. The second phase is optimization, and we are trying for neutral fluid balance. Look at this. This is a fluid status here. You can see that the fluid status is increasing. Now we're not giving any more fluids, so it is neutral fluid balance. In the stabilization phase, we start to achieve negative fluid balance at least 2 days in that first week. And this is what we call late conservative fluid management. Now, in the evacuation with the resuscitation, this is what when we aim for negative fluid balance, and this would be late goal-directed fluid removal. And I want you to know that in terms of the flow of the blood to the organs, in the first few days, from minutes, hours to the first 24, 48 hours, we're in the ebb phase of the flow. And then we transition from the ebb phase into the flow phase. That will actually put some risk about our organs in terms of the first few minutes, hours. It would be the initial insult and the hyperperfusion. Then when we start reperfusing, we're going to have reperfusion ischemia on the different organs. And then the global increased permeability syndrome is seen within after 5-7 days of the insult. And of course, if we diurese the patient very excessively, at that time, you're going to go with the risk of hypoperfusion. So the 4 questions that we need to answer for when to start fluid, when to stop fluid, remove fluid, and stop removal. Of course, this is a very busy slide, but I wanted to go through this very gently with this nice graphic here. We resuscitate our patients when we have signs of hypoperfusion. You can see mean arterial pressure is decreased, capillary refill time is decreased, lactic acid is elevated. You can assess perfusion through the CO2 gap if it is elevated, and the central venous saturation that is elevated too. All those would be signs of hypoperfusion. Of course, the saturation would be dependent on the cardiac output, also elevated or decreased. But those are the signs of hypoperfusion. Now, in addition to that, you need to have evidence of fluid responsiveness. Okay? And if you go with static volumetric preload measures, you're not going to be able to assess that. But those would be if you have global end diastolic volume index. If it is less than 640, it may mean that your patient is hypovolemic. Right ventricular end diastolic volume index less than 80. Okay, that is static volumetric, not very good actually. Static preload pressure, actually it's with the CVP is a flip of the coin. If you have a Swan-Ganz and you're monitoring the occlusion pressure, it would be better. If it is less than 10 millimeter mercury, it may mean that your patient is hypovolemic. But you need to have a dynamic measure for fluid responsiveness. And I'm not going to go through the details of this because that would be another lecture actually, but we can use the passive leg raising, and that's what I prefer. But with this, you need to identify there's a change in the stroke volume. You can use any method, but what I do is the VTI, if you know how you do it on the ultrasound, and if you have the ultrasound with the Doppler capability. Then you can do the end expiratory occlusion test and measure the cardiac output. Stroke volume variation, pressure or systolic pressure variation or pulse pressure variation above 12%, and then IVC collapsibility. If the patient is not on the ventilator, we call it distensibility if the patient is on the ventilator. Now we start to de-escalate once you achieve those targets in a way that they do not show hypovolemia. And you can see the numbers actually that will indicate that the patient has enough fluid. And once those numbers started to go the other direction, at that time you would say, well, I need to resuscitate. The blood pressure could be normal, lactic acid less than 3, and negative passive leg raising. At that time, you measure the abdominal aortic perfusion or the intra-aortic pressure. If it is more than 12 centimeter or 15 centimeter of water, you start thinking that maybe I'm giving too much fluid here. If the global end diastolic volume now is more than 850, or the left ventricular end diastolic index is more than 14 centimeter per meter, or the extravascular lung water index is more than 10 at that time, or the capillary leak index is more than 60, at that time you would think that maybe I need to start the resuscitation. The pulse pressure variation, systolic stroke volume variation less than 12, or if you have high VIXUS score, and we're going to talk about that. But I want to put that in a better way, because we don't have all those resources everywhere. So you can utilize whatever you have available at your ICU in order to determine, do I have a trigger for the resuscitation? That could be, number one, increased weight of the patient and positive fluid balance. And this is what happened with our patient. And the patient could be delirious because of cognitive issue related to some cerebral edema. Now, some basic laboratory parameters could be hemodilution, but that has to be intravascular dilution actually to cause the hemodilution. But if you have a capillary leak index more than 60, that may indicate that you have too much fluid on board. And then you go with radiological signs. You have ultrasound. If you have B lines bilaterally, if you have pleural effusion, that's extra fluid. If you have low inferior vena cava collapsibility index, as we talked about, less than 18% if the patient is intubated, less than 50% if the patient is not intubated. And then we have high-grade VIXUS, and we'll talk about that next. You assess the cardiopulmonary function if you have any of those devices that can actually assess fluid responsiveness. So what we're looking for here, there's no fluid responsiveness because you're actually overloading the patient. And if you have increased filling pressures or volumetric preload parameters on the ultrasound. And then if you have low pulse pressure variation or stroke volume variation. You also may look at end organ functions. You may see that intra-abdominal pressure is elevated more than 15. Your bilirubin is increased, your creatinine is increased. All those would be together would actually make a case that you need to de-resuscitate your patient. The IVC diameter is where you start with actually when you look at the VIXUS score. If it is more than 2 centimeters, you go to look at the hepatic vein, then the portal vein, then the renal vein. And you can see those abnormalities going from normal if you have the systolic wave more than the diastolic wave. When you have reversal of these two waves here, meaning the systolic is less than the diastolic, that is abnormal. And it is severely abnormal when you have reversal of the stroke, where it's actually on the other side of the line. With the portal vein, this is what you need to see normally, actually, no variation. When you start seeing pulsatility, this is abnormal, and it is severely abnormal when it is more than 50%. That means that you're transmitting the right-sided pressure into the portal vein, and that indicates fluid overload. In the renal vein Doppler, normally you see continuous monophasic flow wave. If you start seeing discontinuous biphasic, like the systolic, diastolic, at that time, you will see that this indicates fluid, abnormal fluid status, and it would be severely abnormal if you have discontinuous monophasic flow wave only. And you can see this, this is normal, S wave, D wave. When you start seeing fluid overload, you can see the S is less than the D, and then reversal of the S. You can see this is systole and this is diastole, and this is for the hepatic vein. For the portal vein, normally you see this monophasic flow wave. If you start seeing pulsatility like this is abnormal. If you start seeing more than 50%, this is severely abnormal. And in the renal vein, if you should see, actually look at the venous. So this is the one below the line. This should be continuous monophasic. When you start seeing those discontinuous biphasic, this indicates fluid overload. And when it is monophasic like this, you lost the systolic. This is, of course, systolic would be embedded in the above the line here. This is the severe abnormal. There's a very nice webinar that was given by Dr. Sanusi. Is available on our YouTube channel also about congestion cascade. And he actually used the ultrasound to valve to the LV, LA, pulmonary veins, lungs, pulmonary artery, and then RV, RA, all the way to IVC. The viscous viscous score is only assessing the IVC, the hepatic vein, the portal vein, and the renal Doppler vein, the renal veins. With the congestion cascade is more inclusive to the whole system. Now, let me look at the evidence. Okay, so I'm going to put this again. What evidence do we have to support what we're doing? And let's see in terms of the outcomes. Now, the reason why you see different colors here is because we have different results. And you can see actually in the resuscitative phase, I'm going to be talking about the early goal-directed therapy. And Rivers from Henry Ford in Detroit, I think 20 years ago now, 21, 22 years ago, showed that if we are aggressive with fluid and have specific parameters, we're going to improve outcome. Well, that was not replicated 17 years after in three major trials, the PROCESS trial, the PROMISE trial, and the ARISE trial. But the reason being is actually because those patients already received 30 ml per kg of fluid, even before randomization. And you can see how this would indicate that the early goal-directed therapy that was initially started with a small study at a single institution now has evolved into usual care. So that's what we do all the time. We give our patients 30 ml per kg on average, whether the patient was in the treatment intervention or in the intervention arm or in the control arm. So that's why we did not see difference between the ARISE, PROMISE, and PROCESS in terms of mortality, because the fluid differences in between the two groups were the same. However, earlier studies, when you see the Rivers here, the fluid differences between the two groups was huge. So it indicated that we're not resuscitating our patients adequately. So the early goal-directed therapy still actually is something that we follow on our patients. However, we don't have to go with those specific parameters of the mixed venous saturation, the hemoglobin, of course, target, and the CVB target. We only assess for fluid responsiveness and make sure that your patient has enough fluid. But I'm going to mention a very interesting study here, and this is in Africa in children with severe infection. What they did with those patients, I think there are how many patients? Maybe I don't have the number here, but around 400 patients, if I'm not mistaken. But for those patients, they actually divided them into 3 groups. Fluid bolus, whether it's albumin or saline, and no bolus. And they ended up with a no bolus group getting on average 10 ml per kg, but in the bolus group around 40 ml per kg. Look at the mortality. Was better if you did not give bolus. And this is the Kaplan-Meier. Mortality is better if, that's why I put it in red here. So giving fluid to those patients was harmful, actually. It did not benefit. There was another study in Tanzania that had similar results in adults, but this was not replicated in different studies around the world. So I just wanted to mention that generalization is very important. Now we look at the mandated emergency care in New York. Actually, after all those early goal-directed therapies, it was mandated in New York that you follow those strategies. And specifically, the 3-hour bundle that was actually published by the Surviving Sepsis guidelines. So that was mandated in New York, and they looked at close to 50,000 patients in 170 plus hospitals. And you can see here that, yes, you can see increased mortality if you delay the completion of the 3-hour bundle. And that would include blood culture, antibiotics, and lactate measurements. You can increase mortality if you delay antibiotics. But in this specific study, delaying fluid therapy was not associated with increased mortality. And another study, the same actually mandate from New York sepsis care mandate, but this is in children. And this, when the 1-hour bundle came out, you can see that the completion of 1-hour bundle was associated with better improvement in mortality. And you can see here mortality shifts after 1 hour actually if you delay completion of that elements of the 1-hour bundle. Now we have the Clovers, and the Clover was actually designed to answer the question whether we can be restricted in our fluid strategy. And what you see here is 2 groups. The first group is restrictive strategy, and the second group is liberal strategy. They aim for vasopressor initiation early with restriction of given fluid to certain indications. and compared to given fluid early and vasopressors late. Total of 1,563. Of note, even in this study, those patients prior to randomization received between 1 to 3 liters on average. But after that, restricting fluid was not different in terms of 90-day mortality compared with liberal strategy. So it is neutral study. You still need to give the initial fluid, but after that, you need to restrict the fluid. There's no reason for you to be aggressive. And then the only study that would actually look at the de-escalation, the Clover study was within 24 hours of sepsis presentation. Now, the classic study is actually within the first 24 hours all the way for 5 days. So we have more inclusive of the optimization and stabilization phases. But again, those patients were randomized to restrictive fluid versus standard fluid. In this trial, those patients received at least 1 liter of fluid prior to randomization. 90-day mortality is not different. Restricting fluid is not going to be associated with better mortality or worse mortality. And you can see that those patients really had more fluid if they were in the standard therapy, standard fluid arm compared to the restrictive fluid arm. So the study, again, neutral, is not going to be, is not associated with worse or better outcome. Now, moving from the stabilization to the resuscitation phase, and we know the FACT trial. The FACT trial is back, I think, 2005, and this is in ARDS patients. After stabilization, within 48 hours, 1,000 patients were randomized to receive either conservative strategy compared to liberal strategy, and you can see that they ended up within 7 days having 7 liters on board here on average. Here, they were in the minus. So mortality rate was not different. However, we were able to extubate those patients easier or faster. So that was a positive study in terms of length of stay on the ventilator. There's a meta-analysis that was published, let me just see the, in 2014, published in 2014, and it included around 20,000 patients, came from 11 randomized control trials, but included observational studies and even case series. And in this study, you can see mortality rate for fluid restriction was better compared to liberal fluid therapy. However, if you take a look on those studies that were included in the trial here, in the meta-analysis, yes, you can see better mortality. Look at the heterogeneity, almost 90%. So it's not actually very good meta-analysis to rely on in terms of inferring guidelines to our practices. But another meta-analysis that included only randomized control trials did not find any difference in terms of mortality, but the number of patients were low. And then it's clear that we needed a good randomized control trial to answer the question whether if we give Lasix to those patients would be associated with better outcome. Unfortunately, the GODEF trial was designed for that purpose. However, the trial was terminated or stopped early due to imprecise fluid balance assessment. I don't think fluid balance alone should be used in terms of the determination about which arm of the study they would go to. This is the first version, and I think they're looking at coming up with a second version. Hopefully this will be adjusted. They only included 40 patients, so I did not present the results of this. So it is clear that the current evidence is limited by the lack of high quality RCTs, the small sample sizes, heterogeneity of patients population, and even heterogeneity of applied resuscitation technique. That could be either combination of diuretics, application of PEEP, giving albumin 20% followed by diuretics, doing the PAL treatment, which is PEEP equal to intra-abdominal pressure, plus albumin 20% plus or followed by Lasix, or doing any renal replacement therapy with ultrafiltration. I want to summarize that what I do with this background, with this inconclusive evidence, I think it's very difficult to be guided based on the literature. And putting it all together, I think the best way to approach this is the following. Number one, let's limit fluid administration to patients with objective markers, meaning that let's give fluid to patients if they have, number one, evidence of hypoperfusion and together fluid responsiveness. You don't want to give fluid to a patient who's hypoperfused but not fluid responsive. You want to give fluid so you can increase the cardiac output. And then they can benefit, or potentially, because we don't know yet if this is actually going to be improving also outcome or not, but potentially they can improve perfusion to the organs and improve outcome. And if they don't show fluid responsiveness, you're only going to be using vasopressors. And then you start de-escalating, and look at the difference. You de-escalate, and the reason why we de-escalate is for organ rescue and support. And the indicators would be, I need to have adequate tissue perfusion or objective measures of no responsiveness. So if you have no adequate tissue perfusion, but the patient is not responsive, you don't give fluid. You need to have objective measures of fluid responsiveness in order to continue giving fluid. So you de-escalate if you don't have this responsiveness anymore. Okay. And if the patient is fluid responsive, but he has adequate tissue perfusion, while you're giving the fluid, you need to de-escalate. See why it is or. So if you have adequate tissue perfusion, you don't need to give any further fluid, and you don't need to assess for fluid responsiveness. If the patient does not have adequate tissue perfusion, at that time, assess for responsiveness. If there's no responsiveness, at that time, don't give fluid. And the last thing is de-resuscitation. And de-resuscitation would mean that you need to have organ dysfunction, number one, and fluid overload assessed by your objective measures. Or if you have fluid overload alone. Okay, so it's either in combination or alone. And I'm going to put this on the last slide here. So if you put it all together now, you can see in the resuscitation or the escalation phase, I need to have hypoperfusion evidence and fluid responsiveness evidence. Together, I can give fluid. In the optimization phase, I need to restrict giving fluid if I have adequate tissue perfusion, or if I don't have evidence of fluid responsiveness. And then, of course, you're going to go through some de-escalation here with negative fluid balance. Going to de-resuscitation, you need to have the evidence of organ dysfunction and fluid overload or fluid overload alone. With this, I'm going to end up here. Thank you very much. And I think we can go with the questions. Dasber?
I think Tasbir sir may be busy with his patients. Today he is on call, I think. So we can continue. I am Dr. Motiul Islam. I thank Dr. Mazen Karela. Actually, what a wonderful lecture. It was really wonderful and really informative. And I think the audience are more and more audience should be present lecture like this. And here, of course, you showed a lot of studies and a lot of evidence that the initial assistance should be goal directed and target directed. And of course, we have to know when to stop and we have to know when to de-escalate, right? So can I invite in? We have 3 panelists here, and of course I am also one of the panelists. Can I invite Professor Mohammad Nurul Huda? Of course, he's a nephrologist from Chittagong Medical College, and he deals a lot of patients with fluids and fluid overload also. And can I mention some thing about to talk that the one thing is really new to me, that Professor Mazen told us about the renal compartment syndrome. It is a little new for me. Actually, we are aware about abdominal compartment syndrome, of course, the intercompartment, the cerebral compartment syndrome. It is familiar to us, but a little newer topic for us, that the renal compartment syndrome and hepatic compartment syndrome. Okay, sir, Professor Nurul Huda, sir, can you put some comment, please now?
Thank you very much. I first congratulate Mazen Kerala for his excellent and outstanding and brilliant lecture. I learned a lot from his lecture, and actually this is very helpful for our students, our colleagues, and everybody in Bangladesh. As we are in resource limited situation, there are a lot of for fluid management, there are a lot of machineries needed actually for assessing the fluid responsiveness and fluid management and fluid status. In our nephrology patient, most of the patients are fluid overloaded, and especially in dialysis patient, and we need fluid measurement very accurately. And to me, I always told my students, as our country's resource limited situation, first we have to manage fluid depletion state like shock. So how we can assess the shock? We can assess the hypovolemic shock, cardiogenic shock, septic shock by three simple measures, like cold periphery, jugular venous pressure, and hypotension. In case of hypovolemic shock, postural hypotension, cold periphery, and low JBP. In case of cardiogenic shock, hypotension with narrow pulse pressure, cold periphery, and raised JBP. And in case of septic shock, it is hypotension with wide pulse pressure and warm periphery and low JBP. So if I can summarize, JBP only raised in septic shock, in cardiogenic shock, and periphery only warm in septic shock, and in three cases hypotension is there, but in hypovolemic shock there is a postural drop. In case of cardiogenic shock there is a narrow pulse pressure, and in case of septic shock there is a increased pulse pressure variation. Let us think about fluid responsiveness. Dr. Kerala nicely mentioned and elaborately mentioned the fluid responsiveness. Actually, this is many of things from his lecture I knew first time in my life, and as we are not practicing this type of procedure because of low resus. I am again mentioning that there is a low resus situation in our country, but we can do the 2021 sepsis guideline clearly mentioned that dynamic measure is superior than static measure. For dynamic measure, actually, pulse pressure variation, stroke volume variation, we need the tools. But for an infravenous diameter or collapsibility, we need the ultrasound machine. I always ask our ICU colleagues, please do infravenous diameter or collapsibility for assessing the fluid responsiveness. Everywhere I told them, but we can do easily in word passive leg raising test by we can raise the leg by 45 degrees and forget about stroke volume and cardiac output. This need a special device. I think Chitra device is used in USA, but we can do mean arterial pressure. We do not need the device. We can do pulse pressure. We do not need the device. So if there is a variation of pulse pressure or mean pressure, in a resource limited situation, in a hospital general ward, we can think about fluid responsiveness by these two simple words. And finally, I should comment about fluid. What type of fluid we need? We always tell that normal saline is not a normal saline, it is an abnormal saline because it causes hypochloremic metabolic acidosis. In case of septic shock, there is already lactic acidosis. If we give normal saline, it causes much more hyperchloremic metabolic acidosis. So in that case, we especially do two landmark study, salted study, and for fluid, salted study and SMART study in non-critically ill patient and critically ill patient, they clearly proved that balanced crystalloid is superior than normal saline. So in case of shock or septic shock, we usually prescribe normal saline, balanced crystalloid light, Hartmann solution, just like that. And when we cannot reach mean pressure by this situation or that by the saline, we have to add on vasopressor like noradrenaline. In most all kinds of shock, noradrenaline is the first choice, except anaphylactic shock where adrenaline is the first choice. And in case of bradyarrhythmia, we can give dopamine, but most of the shock, first choice is noradrenaline, then add on vasopressin, and then adrenaline. So, and colloid is not encouraged in case of fluid resuscitation. We all know about this. And if vasopressor about fluid, about antibiotic, he clearly mentioned we have to administer it immediately within especially 1 hour. We have to start the antibiotic, and after culture sensitivity we can change. And if we have a MRSA suspect of high risk of MRSA, we can add MRSA. And if MDR organism, we have to give 2 negative antibiotic. And infection control is very important in case of shock or septic shock. And there's some no's. I always tell there is no diuretics, no low-dose dopamine, phenoldiazepam, aminoglycoside, or NEC in case of AKI and shock. So with these few words, I again thanks Professor Mazen Kerala for his outstanding and brilliant lecture. I learned a lot from his lecture, and I hope our students learn a lot from his lecture. Thanks again, Kerala.
Thank you very much for your comments. Actually, it adds a lot to what I presented in my lecture. And I want to emphasize, and it is clear that we face this in different parts of the world where we have limited resources. And thank you very much for outlining those methods that you can assess in terms of whether the patient needs fluid or not. But I want to say also that the Clover study and the Classic study, they both actually help us in those limited resource countries, where because restrictive fluid after the initial fluid bolus for the patient did not show any difference. So in fact, actually, if you stabilize the patient in the early phases and you have evidence of hyperperfusion, you don't have very clear evidence to assess for fluid responsiveness, but you already mentioned a couple of easy ways to assess for fluid responsiveness that are not requiring machineries. If you do this, after this initial phase, restriction of the fluid is not going to be associated with worse outcome for you. And you don't need to be aggressive with the fluid therapy. Just assess for the perfusion, and if your patient is perfusing, do not be aggressive with the fluid. Thank you.
Thank you very much.
Excellent discussion. Thank you, Professor Huda, and again, Dr. Mazen. Yeah, Dr. Tazvi is here, and I like to hand over the moderatorship to him, please. Please, sir, carry on.
You're doing great. Right. You're doing. I was actually listening, and then I have to leave a little bit because one patient was crushing. So
okay, right.
I just intubated. So thank you so much, Dr. Kerala, taking the session. It is very time demanding, you know, the topics. and really appreciate. Motiu, did you went through all the panelists and Professor
No,
Nurul
no,
Huda
no,
and
no.
Fatima?
Myself is one of the panelists. I am spared, and Dr. Fatima is here. He didn't speak.
Okay.
Me as
Okay,
a
so
panelist, I should talk later on.
okay.
Dr.
So
Fatima.
only Nurul Huda said something, right?
Yeah. Right.
Okay. So I'll go to Fatima, to you. Do you have any comments on the presentations today? Fatima. Fatima is, your microphone is off, is mute.
I must appreciate Dr. Marjan Kerala because it is a wonderful presentation. Not only that, it is a very informative. It is an amazing presentation, and I feel it is a wonderful presentation I have heard last few years. Thank you very much for presenting this topic. And one important thing is that every patient is different. You mentioned that 50% patient might not responder, might not be fluid responder, that fluid might be harmful for them. And every patient is different, and fluid resuscitation should be depending on organ perfusion, intravascular volume assessment, and cardiac output assessment also. And one more thing is large fluid, low fluid, and adequate fluid. Demarcation is very difficult, very difficult. We need to monitor the patient in every minute. If we are in resource limit setting, we have to think is a low fluid, or it is large fluid, or adequacy. Early adequate
Give
resuscitation
another
and late
different.
conservative. Late conservative is the adequate fluid resuscitation. But
Give only
early
4.
adequate resuscitation, what is adequacy? We need to use ultrasonography, IVC, aortic, and portal, and also hepatic veins, also renal veins. So these are the amazing thing you mentioned, I feel. And one more important thing you mentioned, that fluid is a drug. Fluid is a drug, so it needs a dose, duration, and de-escalation. Otherwise, patient might not be benefited with huge or large fluid, may ended in extravasation, extra fluid overloaded, and outcome will not be good. And resuscitation, when it is adequate, or it is sometimes conservative resuscitation, fluid resuscitation is sometimes better than liberal fluid resuscitation. Thank you very much once again for presenting.
Thank you very much for your comments. Indeed, very true, actually. It should be individualized approach. And I want to mention also one more thing here. The fact that we have fluid responsiveness in a patient doesn't mean that we're going to improve tissue oxygenation. So we may have a signs of hypoperfusion, and then we show that on the parameters that we do in different machines that we utilize, that the patient may benefit from the fluid. If we give that patient fluid, doesn't mean that we're going to improve tissue oxygenation, because we're dealing with septic patients. They may have tissue injury already because of the cytokines, because of the mediators that you release, because of the hypoperfusion. Thank you.
Thank you very much.
Thank you so much. Thanks, Fatima, for your wonderful comments. And thank you, Dr. Mazen Korella, to supplement that. So I will go to the youngest panelist in our session, Dr. Motiul Islam. Motiul.
Thank you, sir. Thank you, Dr. Mazen Kerala. I will echo Dr. Fatima Ahmed's comment that it's a truly wonderful lecture, sir. What a lecture it is. It was truly practical and work-oriented. And just I work in a center. It's semi-resource oriented. I could say it's not resource oriented too much, but we have some liberal liberty to use some machines and to do some investigations in our center. Just we try to follow some aspects. We follow that if we do not get result, do not get response to a fluid, we do not give. So if the fluid response is there, we should go for fluid resuscitation. And actually, SLR passive leg test is not feasible for our center because we cannot measure the response. We can pull the leg, but you know, a lot of confounders are there, but we cannot measure, so we do not practice that. But everybody of our team can do the ultrasound. We carry the ultrasound machine on the rounds and follow-ups. And every time we use that the distensibility, infusion vena cava distensibility or the collapsibility index, and it helps us a lot. And lactate is a good marker. Carbon dioxide gap is also a good marker. Combination of lactate, carbon dioxide, and the dynamic variation, we can generally find the end point of the resuscitation. So every patient is individual, every pathology is individual. So we need to find we like to find the end point of resuscitation, and generally it is well defined. And after that, after stopping, at a time we need to go for resuscitation. And when the tornado is stopped, when all the patient is stabilized, then we think of it. And you already mentioned various methods, active method, passive method, but one method is well practiced in our center, that albumin and lasis combination, albumin and furosemide combination in the de-resuscitation phase. And generally, in our center, we thought that it works better. And one thing I should mention that among the other complications of fluid overload, many often we have to deal with the abdominal compartment syndrome, and many times it's a nightmare for our center. So you have already mentioned everything and already shown a lot of evidence. Hopefully this lecture will be recorded, and I will recheck and re-see your lecture, and I will present it to my students. So thank you, Professor Mazen. Thank you again.
Thank you, Motiul.
Thank you
so
for your
much
comments.
for your comments. But I'll just go back to Dr. Kerala about your comments on two things. So I just want to know his opinion. One is the passive leg raising test. What's his experience, and what's your experience about the passive leg raising test using Cheetah device or FlowTrack versus looking at the IVC only by echo or ultrasound? So which one do you do, and which is your favorite? Thanks, Dr. Mazen Kerala.
So thank you very much, actually. I wanted to say that there is no favorite test, actually, for me. What we use is combination of different parameters from different methodologies. Each one has its own disadvantages. And of course, there's a lot of issues with the passive leg raising in terms of how we do it and assess the response. So in fact, if you combine things together, and that's why I put it in this graph here together, we look at the static measures along whether it is volumetric or the pressure measures, and we combine with whatever we have in terms of the dynamic measures. I like still the passive leg raising with VTI because we're able to utilize this at the bedside, and we learned how to measure the VTI. But I think the end expiratory occlusion test, if the patient is intubated, is actually remarkable. And I put them in this order here, that this has the highest to be supported in the literature, followed by this one. I have another slide, but it's not available on this presentation. And then the stroke volume variation, the pulse pressure variation. And the last thing would be the IVC collapsibility. But again, combining this together to give you more data to be convinced that your patient, number one, is hypoperfused, and number two is hypovolemic and fluid responsive, would be the best answer to your question, Tasmir.
Thank you so much. Probably we'll do another session about the hemodynamics as well, about that passive leg raising test, which changes aortic velocity time integral, or looking at the stroke volume. I know that before we used to give fluid to see the fluid responsiveness, but that is irreversible. So, and too much fluid is not good for the failing heart. So we don't do fluid challenge tests. We mostly do passive leg raising tests. I totally agree with Dr. Kerala that it's a combination of both. The echo is such a nice tool in shock patient. Tell you, just put the probe on the chest. If the left ventricle is not working, cardiogenic shock. If the right ventricle is dysfunctional, probably it's a P. If the big effusion, probably is tamponade. If you see left ventricle is hyperdynamic, telling you more sepsis or hypervolemic shock. So echo and then looking at the IVs. So it's very important to do the echo for every shock patient. So so thank you so much. I know he has spent a lot of time. So last I'll go to the quiz. Question is done?
No, not yet.
Okay, let's do the quick quiz question. And we'll pick up the Nafisa. Please keep an eye who is the winner, and then we'll give that token, the gift to the winner.
So the first question: which of the following fluid management strategies in patients with sepsis may be associated with an improved outcome? A,
And
early adequate, late liberal fluid management. B, early adequate, late conservative fluid management. C, early liberal, late conservative fluid management. D, early liberal, late liberal fluid management. Tell me when I should move to the second question.
so see, everybody answered B, but Monira, Oppo, Protoy, Ribaba, and Tanzila. The question is, what is the right answer to Mazan Karalla and Nafisa? Do you know who answered first?
Yes,
You know,
sir.
maybe keep track of the 10 questions and then
Okay,
see which
so this one
has
is,
the highest number.
okay, so what is the answer for this question?
The answer is, as we showed in the two studies, observational studies, that early adequate, late conservative fluid management is the answer to this question. Again, the answer is actually what we're seeking that may be associated with improved outcome. Okay, so we are not sure 100%, but it may be associated. You need to adequately resuscitate your patients early, and then at later point you can do conservative fluid management. The answer is B.
Very good. Go, Nafisa, keep an eye who answered first. Second question.
Which of the following is true regarding the resuscitation phase of septic shock patients? Select all what apply. Or this is, you need to select, maybe there's more than one answer. A, 50% of patients are generally fluid responsive. B, volume expansion may not persist for more than 30 to 60 minutes after fluid bolus. C, Frank-Starling curve may be shifted downward and to the right. D, patients who were initially fluid responders rapidly become non-fluid responders.
So we have few answer from Norshin, Ribaba, Oppo, Tamit, Monira, and Protoe. So look like many said ABCD, many said ACD, one said B.
Okay, so the answer is A, B, C, D, all of them actually. And I presented in my lecture the studies that actually support each one of this. So around 50% of patients are not responders. And we lose volume expansion. We lose the value of volume expansion within 60 minutes. Frank-Starling curve may be shifted to the right and downward in patients with sepsis. And finally, patients who were initially fluid responders, they rapidly become non-responders, and as I presented the study for this. So the answer is all of them. Which of the following studies indicated that patients with ARDS who were managed with restrictive fluid strategy have improved outcomes in terms of less time on the ventilator? Is it the FACT trial, the CLOVERS trial, CLASSIC trial, GODIF trial?
Norshin answer A. Tamid A, Protoe A. You got 5 seconds to finish. Ribaba says B. 2 more seconds. Okay.
Okay, so the answer is the FACT trial. It's that was done in 2005 and showed that those patients with restrictive fluid strategy, they stay on the ventilator less. Question number 4. Which of the following studies investigated fluid strategies in the optimization and stabilization phase of fluid resuscitation or fluid management? FEAST trial, A, B, CLOVERS trial, C, CLASSIC trial, D, GODIF trial. So we're looking for the study that included the optimization and stabilization phase, which is days after the initial resuscitation. Which study is that?
So there is Tahamid answer D, Ribaba C, Norshin C, and Protoe C.
Okay, so the right answer is, should I give it?
Yeah.
So it's a CLASSIC trial. The CLOVERS trial was only for 24 hours. The CLASSIC trial is the one that extended for 5 days and included the optimization and stabilization phase. Question number 5. Which of the following statement is or are part of fluid stewardship? And check all what apply. A, fluid is a drug. B, fluid should be given based on clear indication. C, fluid therapy has a toxicity. D, you need to know when to remove fluid. You need to check the statements that are part of the fluid stewardship.
Okay, the answer, mostly all answer A, B, C, D. I think Norshin answered the first. The answer is A, B, C, D, Dr. Kerala.
Correct. Yes, all of them. Perfect. And we talked about that. Next question. Your goal in the stabilization phase of septic shock is to maintain perfusion and organ support through which of the following fluid targets? So again, stabilization phase, what do you need to do in terms of fluid? A, continue maintaining a positive fluid balance. B, maintain a neutral fluid balance. C, achieve a negative fluid balance. with 2 consecutive negative balances within the first week. And D, continue aggressive negative fluid balance. The answer?
Mostly answer B. Means a couple of answer B, couple of answer C, and couple of answer BC.
Okay, so the answer is C. Remember, this is stabilization. So this is not optimization. In optimization, it's neutral balance. In stabilization, you need to start thinking about achieving a negative fluid balance. Still not aggressive fluid balance.
So only Tanzila and Rashmi got the correct answer. I think Tanzila answered a little earlier than Rashmi. Okay, next question. Nafisa, keep an eye on that.
What does the following renal vein flow waveform indicate to you? Is it normal renal vein flow waveform? B, discontinuous biphasic waveform indicating mild to moderate fluid overload. C, discontinuous monophasic waveform indicating severe fluid overload. D, discontinuous biphasic flow waveform indicating volume depletion.
Okay, the answer so far, Ribaba said B, Noshin says B, Oppo says C, and Monira C, Rashmi B. So what's the answer?
And the right answer is B.
B.
So
Ribaba got
you can see systolic and see the diastolic. Usually it should be monophasic. Once you see pulsatility like this, that means that right-sided pressures are now started to be transmitted all the way to the renal artery, to the renal veins. So the answer is B. Okay. What does the following portal vein flow waveform indicate? Normal fluid status, mild fluid overload, severe fluid overload, D, hypovolemia.
Noshin answer first A, then Ribaba A, Protoy A. So a couple of seconds. Any more answers? Anybody? So I think Noshin answered A, Ribaba all answered A. I think Noshin answered first.
And the right answer is A. It is, I see here, there is no pulsatility. It is monophasic waveform for the portal vein. And this is normal fluid status. Question number 9. The mortality rate in the intervention arm of the FEAST study involving children with septic shock who had no fluid bolus was, so again, this is no fluid bolus in the FEAST study, and we're talking about specific population in that study. The mortality rate was A, similar to the control arm, B, higher than the control arm, C, it was difficult to be determined, D, it was lower than the control arm.
So answer came out as Ribaba says D, Monira B, Rashmi A, Noshin B, Oppo D, and Tanzila B. What's the answer?
And the right answer is D. The mortality rate was lower than the control arm.
D for David.
D, David, yes. For those children who were not given fluid bolus in Africa, they had lower mortality rate. The average fluid that were given 10 ml per kg compared to 40 ml per kg in the liberal or the bolus arm. So the answer is D as in David.
So Ribaba and Oppo got the right. I think Ribaba answered faster than Oppo. The last one.
How would you approach a septic patient with hypoperfusion and stroke volume variation of 18%? A, give fluid bolus. B, give norepinephrine. C, give dovitamin. D, give Lasix.
Okay, everybody got A, but Nashin answer first, and but Monira says B. What is the answer?
Okay, and the right answer is this patient has hypoperfusion and has evidence of fluid responsiveness. That number should actually, this is stroke volume variation, anything above 12% means fluid responsiveness. So the answer is A, you need to give fluid bolus for this patient.
So Nashin, I think Nashin, Pratyay, Appo, and Ribaba answer right, but Nashin, I think, was faster in responding the question. So I think we are done with all 10 questions. Thank you so much, Dr. Kerala. It was a beautiful questions, very challenging and practical. So Nafisa, do you know who is the winner?
Yes, and Noshin Tabassum, she answered 4 times. So she's the winner.
Okay, thank you. Congratulations. I think all the participants did very well, I must say, because they answered most of the, I think majority they got it correct. So they're very attentive, just telling us, and they listen to the lectures. And I'm saying it's all credit goes to Dr. Kerala to keep the audience, in focus. So, and Tabassum, will you please in the chat box give your address so that we can mail that one to you as a token gift? Just mail, type your address in the chat box. And Nafisa, please take a note. So I think we are done. I want to thank you all the panelists, Professor Nurul Huda, Fatima Chaudhry, Fatima Ahmed, and Motiul Islam for their precious time. I want to thank all the participants who participated in this session, and I'm pretty sure they learned. And I want to thank Dr. Kerala, who actually did a tremendous job. And I actually learned so much as well from this lecture. And I'm hoping we'll get Dr. Kerala. I want to let you know one thing. Hopefully in February, the Planetary Health Academia is organizing the global summit. That is a multi-speciality conference in February 23rd and 24th. And I'm very hopeful we'll get Dr. Mazen Kerala to be one of this, not only the speaker, also will run a course on.
Oh, excellent. That will be excellent.
Yeah, he'll be with us, so inshallah, and so that is the plan, and I'm pretty sure I'll get Dr. Kerala more and more in our session. Thank you again. I know Dr. Kerala, you have to join him. You have to join him. You have to catch a flight now. So I want to thank everybody, and inshallah, we'll see you again.
Thank you.
Thank you very much.
Thank you, everyone.
Thank you, sir.
Everybody.
And keep in mind, Nashin will hopefully send you the gift soon. Take care. Bye.
Bye.
Thank you.
Bye.
Bye.